So for our final presentation of the day, I know it's been a long day for everyone, but I'm sure you will find this very, very interesting. It'll focus on the work of over 400 organizations, 800 individuals from 70 countries, doing work to accelerate the use of genomics in medicine and to advance human health. So I'm very pleased to introduce Peter Goodhand. He's the Executive Director of the Global Alliance for Genomics and Health. He's played a very key role in its creation and was appointed as its founding director in 2014. In fact, I was in Vancouver just last month for their 4th plenary meeting. I was honestly struck by the parallels of what they are doing and what I've experienced for the last dozen or so years in the kind of the core digital health agenda. Members were there working on frameworks, working on data issues, data sharing issues, technical issues, policy issues, ethical issues, through work groups and projects, and it just blew me away what they were able to do. And it just really kind of set the tone for me when an individual got up in the Q&A session after one of the talks, and he was from England, and he had recently, or not, maybe not recently, but had a bone marrow transplant. And the donor was a woman from Germany. And it was only through this kind of work and this kind of use of that data that this individual was alive. So it was a very moving story to hear that. In addition to all of his other tasks, Peter was appointed as the interim president for the Ontario Institute for Cancer Research back in May of 2016. Prior to this role, he was the CEO of the Canadian Cancer Society. And before joining the more charitable sector of our industry, he had a 20-year career in the global medtech technology industry. Peter is also very much a patient advocate, caregiver, and navigator throughout his family's battle with a rare cancer as well.
Work-wise, I'm located about 2.5 kilometers due north of here. But in terms of content, activity, and the things I spend my time on, actually, I'm probably a lot further away from the work you do, and you focus on digital health in Canada, than any other speaker today. So this is a message from a different world, but it's one that's been, from our creation, we've been intent on facing the world that you live in. And as I go through the presentation, please bear that in mind. I'm coming from a different perspective, but with the intent of connecting with you in the middle, rather than missing each other like ships in the night. So when we talk about big data in genomics, this is the principal cause of why can we have big data in genomics, is because we've got the massive reduction in the cost of the sequencing a human genome. If the first one took 10 years and cost $3 billion, today it can be done in a few days and it will cost a few thousand and heading towards 1,000. What's that meant in the last few years is that if we look at one of the largest databases in the world in 2014, it had about 0.5 petabyte of data. Each year, we can now produce 72 petabytes of data just with the latest installation of sequencing equipment. So our ability to produce massive amounts of genetic data is off all scales that people would have imagined 10 years ago. So unparalleled generation of human genetic data. The question is, how do we unlock its potential? From our perspective, in a way that allows it to be shared global. We're all very, very, very similar. Our similarities are much greater than our unique differences. In a way that enables, whether it's precision medicine or personalized medicine or precision healthcare, you get the message. How can we use this treasure trove of data to actually improve human health? The challenge from the people who saw this back in 2012, when we first looked at the problem, was that the data was typically in silos. It was by type, by disease, by institution. The analysis methods were at human scale, and we were clearly moving to where we needed to be at machine scale, machine learning. Humans, we can't train enough smart humans to do this quickly. And the approaches to consent and regulation often stood in the way of data sharing. The fear was that if we didn't act, we'd dump petabytes of data into an already fragmented health information system. And therefore, we needed to organize this new data in a way that it could be more useful. We looked at outside our industry and looked at things like the World Wide Web or smartphones and saw the global interoperability and the choice of when you share. So the technology enables you to share. The choice of what to share and how to share it should remain with the data owner. So the thought was, let's launch a global alliance. It's not quite what we thought in 2013, but we've evolved into it. And from the beginning, this was, even though it came out of the big genomic research shops, it was never about better research, faster research. It was about accelerating progress in human health. And knowing that we were going broad, the sense was that we had to do this through harmonized frameworks rather than rigid standards, because we'd never be able to get the globe to agree, particularly when most of it was coming from an academic setting. So harmonized approaches, responsible sharing. We also didn't want to just be shelfware or diskware. We wanted to actually be used in real life data sharing and catalyze a movement towards more effective data sharing. Listen to those patients with rare disease or deadly cancers and their absolute frustration that healthcare doesn't share data. Well, we can more easily on research, but we weren't doing that. Here are our milestones. We started with a meeting in New York City at the beginning of 2013, wrote a white paper that got some very positive response from the people we needed to have a positive response. And we've gone through a series of plenary meetings. We just finished our 4th in Vancouver. And today we're over 400 organizations, and I'll show you a little bit more detail on that, and approaching 1,000 individual members. What we do is on the left-hand side, and what we don't do directly is on the right-hand side. One of the big fears that people had is that these very large mega genomic centers were actually just trying to suck up all the world's data and give it to them so they can do better research themselves. And in fact, we've spent a lot of time making sure people understand that's not what we're trying to do. We're trying to let you control your data and share it with who you need to share it with, not send the data to us. So we don't do that. On the bottom line is literally the bottom line. The alliance is for people who are committed to responsible sharing of data. It doesn't mean share all the data all the time. It's responsible. And on the right-hand side, probably about a quarter, maybe a third of our members don't actually have any data. They are people in the business of enabling data sharing, but they don't actually have their own data. So we spent several years now working together internationally. We really put more and more emphasis on interoperability than we did when we started. We would have talked about standards. We would have talked about a few centers of excellence and powerhouses. And I think as we've gone further, it's more about connecting hundreds of institutions in dozens of countries. And so it's interoperability is the key. Harmonized approaches, talked about it, pilot projects. And the other thing is, particularly when it comes to genomics, it's both one of the most exciting parts of human health and human identity. It's also one of the scariest, because it doesn't just identify you, it can identify your closest relatives. So if you think about privacy and security, there's a higher test when it comes to genomic data because of its ability to identify others around you. We've had from the beginning a steering committee. It grew from 8 to 14 as a smaller executive committee. I just finished the conference call with them before my talk. Just this year, we've managed to recruit a very senior strategic advisory board. And there's 10 people who work with me around the world based in 3 different countries. And it's their full-time job. Those 10 people organize well over 1,000 volunteers who are in one of those 4 working groups or one of those 33 task teams or in those projects. So it's a relatively small staff of full-time professionals, deep content knowledge, who then organize 1,000+ volunteers. That's our GA4GH steering committee leadership. On the top left, brand new chair is Ewan Burney, a data scientist from EBI Emble in the UK, just replaced Tom Hudson when he left and went to California. And then there's a few co-chairs down the one. I will pause on this slide and say the one thing, if you can read it, you would notice this is at the moment still an Anglo alliance rather than a global alliance. And I spend a lot of my time and energy outside Canada trying to make sure if we're going to be global that we engage all parts of the globe. I'm just back from Africa. I go to Europe tomorrow. Here's that very senior strategic advisory board. They didn't want to be called a senior board because they thought it made them seem old. They are very strategic and very senior, and some of you will recognize some of those names, but the head of the NIH, the former head of NCI, Eric Lander, probably the world's most foremost genomic scientist, or at least one of the best known ones. So 400, I think it's 440 organizational members, 900 and some individuals, 71 countries. Bottom line on this slide is 41% of our membership are actually companies, not academics or hospitals. In this, so they're well represented, and this is not an academic play. This is literally bringing together every sector to work collaboratively. We're underrepresented in patient groups, disease advocacy groups, and we're underrepresented in hospitals. So if I tend to have a hospital participate, it's its research institute, and we need to move more into the mainstream for the application. Recruiting pitch. Host institutions from the beginning, the Ontario Institute of Cancer Research, where I'm based, the Wellcome Trust Institute, Sanger Institute in Hingston, UK, and the Broad Institute in Cambridge, Massachusetts. They've done most of the work, employed most of the people, contributed most of the cost. More recently, we've had support from NIH, Wellcome Trust, Genome Canada, but often to do the work of the alliance, not to run the alliance. It turns out that administrative costs to run even an exciting new dynamic organization are not something that easily resonates with funders. Those are the 4 working groups. I'll only pause on the top one in this case. We came out of big genomic data. We knew that we didn't understand the clinical environment, the world you've been discussing today. So we formed a specific working group to be better at commissioning and steering us into that space. It has a very different role from the other 3, which are actually producing things. It's more of a commissioning, partnering group. Security, we actually went outside because we felt that certainly the world of genomic research, the way you kept your data secure was keep it to yourself and don't let anybody see it, or put it in one big repository. So it was a binary approach to data security, and that's not where we need to be. Those are the number of volunteers involved. You've got everything from 89 on the security group to 444 individuals working together on the data working group. And on the right-hand side, the reason Cancer Gene Trust has only got 15 is it's a very new, it's not yet out of the blocks. I would expect that will have 50 to 100 volunteers relatively soon. So the basic model is those 4 main working groups assess needs and priorities in this space. They form a task team. Task team is time-limited, object-driven, produces a solution or a tool, releases that for public in one of 2 ways. If it goes into the bottom, it could be any data sharing project in the world that's trying to connect health and genomic data. It's freely available. The top is actually what we call a demonstration project, and in those cases, we've got a virtuous, we hope, a virtuous cycle of learning, and that the implementation in that project, we actually get a fast feedback loop to help us improve the product for the next iteration. And from all of that data sharing and initiatives comes the needs that we prioritize, and we're just going to go into a major road mapping exercise in the next few months to govern what we do for the next 3 to 5 years. So far, 55 deliverables, somewhere between the design, the develop, and the deployment stage. When they're deployed, it doesn't mean they're fixed. It means that's the best iteration we were able to put into practice. If we feel it's really, really important, it's got to last a long time, and it's got to be a standard, we'll put a lot more thought in up front and release it, and don't keep it rapid iteration. If we think it's an evolving tool, it's more likely to have rapid iteration. In each of the 4 groups, there's typically one or a couple of major accomplishments. In the data working group, it's a genomics API. It's actually a suite of APIs. APIs are definitely our go-to workhorse for interoperability. In regulatory and ethics, it's a framework for the responsible sharing of genomic and health-related data. I'll pause on that in a minute. Security, they wanted a high-level infrastructure document, how-to at the very high level. And on the clinical working group, I said they don't typically produce a lot, but one of the great things they've done is be able to map the amount of initiatives going on around the world, which when we started, if we thought there were 12, we'd probably found out there were 30 or 40. If we thought there were 30 or 40, there's probably over 100. So even the people living, eating, breathing, data sharing, and genomics had no idea of the extent. So the framework for responsible sharing, it's an ethical framework. It's driven primarily by Bartha Knopers from McGill, with support from Kazuto Kato in Japan and a whole bunch of others. But it's fundamentally different from other ethics frameworks for genomic data sharing. It's grounded on human rights and the right of humans to benefit from science and the rights of scientists to benefit from their work. So rather than being a harm reduction, a risk protection, it's a balance between prevent harm and achieve benefit. We're as likely to talk about the consequences of not sharing data when you should be sharing data as the consequences of sharing it inappropriately. So we try and balance that. It's in 12 languages other than English, and all of that was a volunteer. So somewhere around the world, somebody said, I want this in my language. And we said, well, then please translate it and find a friend or someone to translate it back, because we need to know you're saying the same thing in Portuguese that we're saying in English. The catalog, there are 86, we found 86 initiatives that are somewhere in the eHealth with something of a genomic spin to it, and it needs to be updated. We went in to look for family history tools. A critical point of genomics in health is family history. We thought there'd be 4 or 5 tools. It turns out there are 23 different tools. And I'll just pause on the bottom one. This is most recent. It's actually out of date because every time I present this, somebody goes and checks the catalog and goes, we're not in there. So I think the number now on the bottom is 94 genomic data sharing initiatives. We have the 4 demonstration projects. One is in the area of BRCA risk, the risk gene, or one of the main risk genes for breast cancer and other cancers. So that's one of our demonstration projects. The second one is the world of rare disease. It's got a huge leadership out of Canada, particularly Toronto and Ottawa, where the challenge of finding the rarest of rare diseases has to be addressed globally. You can't do it here. Even sick kids may see one kid every 5 years. That means around the world, there were probably 10, 20, 30 kids every year, which we didn't know about. So a global approach. Beacon is simple data discovery. We see data discovery as a prerequisite to data sharing and data exchange. You can't share data if you don't know who's got the data you need to share. And the Cancer Gene Trust is almost a BRCA equivalent, but rather than a risk gene, a germline gene, in the area of a tumor or a somatic gene. So BRCA, I'll just very quickly go through these. The idea, it's not a bad model for how we try and approach everything, is where we can find consensus, where we can find concordance, where we can find expert opinion, the best agreed opinion in the world on the risk of a certain mutation in a BRCA1 or a BRCA2 gene. Make that knowledge as publicly, simply, freely available to the entire world as quickly as we can. Where there's discordance, disagreement, where we need to bring together experts to wrestle to the ground. Why do they say this? And why is it pathogenic in the US and it's not pathogenic in the UK? Put the experts together, give them a workspace, give them tools, give them algorithms to find out why. That has to be done often in private because it's case-level data. And it can't be shared because it would identify. But to get to the answer, trusted partners have to look at that data together. So BRCA challenge very much is we can bring up the knowledge, put it on a public website. The public website looks like this. You could go and check it out at BRCA Exchange. We had about half a dozen organizations work with us. I think when we started, we had something like 13,000 BRCA variants that we tracked. It's now over 18,000, and we're moving more and more of them into that expert space where we can say with great precision, this is what the world's experts are saying about this particular mutation. How we translate that into clinical decision support in each individual country is a different matter. We're not there yet. Matchmaking, I talked about rare disease. The idea is that a rare disease clinician, a geneticist is seeing a child or an adult with a condition that they've never seen before, they can't identify it, or they've done a genomic sequence, either a whole exome or a whole genome. You've looked at the entirety of their humanity, their DNA, and there's something strange about it, but you can't match that genetic variant to that phenotypic difference. So then you have to find ways of sharing it. When we first went into this, it's now called the Matchmaker Exchange. So it's a professional. This is peer-to-peer. We're just about to work on a public-facing version of it. There are 350 million people around the world who've got one of 7,000 plus rare diseases. In the rarest of the rare, they'll go through up to 8 clinicians before they get a diagnosis. It will take years to simply get a diagnosis. When we started, there were 12 of these databases. Around the world, 12 rare disease specialists had got a database that either had the genotype or the phenotype in their database, their rules, their approaches, their access. You had to go to them and say, do you have somebody like me? Can I join your database? Different rules for everybody. What we've worked for is that, and I heard it today on the Ontario model, this is all about federating these databases. If somebody wanted to ask that same question today with the same information, they go to the Matchmaker database that they are most comfortable with or where they think they get the highest chance of a result, and it will search the other databases. So it will say, I don't have a match, but the match you're looking for, there are 2 potential candidates in Australia and 1 in the US, and then the contact and the connection starts. So a completely federated approach. We probably could do a better job of aligning their matching algorithms and their scores, But essentially, it's a federated approach. The data stays in the country. We're not moving the data. We're sending the questions to the data. In terms of data discovery, it was almost done as a proof of principle. Are people willing to share data? So let's ask the most simple, basic question. Do you have this letter at this position on this chromosome, yes or no? And a single question can't be identifying, can't be that. So the idea was if people are not willing to put that on top of their database, their genomic database, and at least tell the world, do I have this letter at this position on a chromosome, yes, no, then they're probably never going to share any kind of data because it's the simplest of all requests. We spent the last 2 years making that easier to implement, making it a richer query system, and today 25 organizations have lit, I think, 62 beacons. We call it illuminating a beacon. And it's probably 200,000 individuals where you can now ask the question, has anybody in the world seen this variant at this position on this chromosome? The next layer will be, how often have you seen it? And in what circumstances have you seen that? We believe before we can ask those questions, we've got to create some level of identity and registration or data control, access control. So we need some greater sense of security as who's asking the question and why are they asking it before we can lift up more data. But the very, very simple question can be asked by you today. And I call it, these are some of the institutions that have lit those beacons. And in a conversation just up the road at OICR with a colleague of mine, I asked the question, why do you have to ask 60 beacons the same question? And they went, you don't. We could do one simple integrated search. So now if you go to the beacon network and ask the question, it will return results for all 60 beacons as who's got that. And so you're probably 3 clicks away from being able to answer a question that in the old days would have taken you weeks and months and phone calls and going to conferences. I won't actually go into this except to lift up the idea of in Cancer Gene Trust, it's somatic data. It doesn't identify the individual as long as you've removed all that data. There is still a sense, though, of easily shareable public data. And then the thought of when you could link that data to a human being, it needs to be behind a firewall. There needs to be a data steward. There needs to be somebody who's acting as a steward for that human being whose data it is. But we still want the answer. So the idea of public, quick, easy discovery of what can be shared and secure access to what needs to be shared. I'm going to skip that one. No, I won't. Around the world, at least half a dozen, probably more like a dozen, different groups interpreting what does a somatic cancer mutation mean. When we see that mutation in a tumor and it's evolving, what does it mean? What action should we take? What drug should be given or not given because of that? So around the world, these are manually curated databases written by reading journals, attending conferences, doing studies, doing some assays, different interpretations, different people, different data sources. So fortunately, 6 of them have got together and said, this is crazy, this is insane. We can do a better job for the world of interpreting the meaning of cancer variants by pooling the data or finding ways to compare across that same variant. Now look instantly at 6 different interpretations and see whether they agree or not. So variant interpretation. What we've learned is that the boundaries, everywhere I've gone for the last 4 years, the boundary between research and clinical care is blurring, and it's not always through the mechanism of clinical trials. It can be real-world data. It can be data mining from health records. It's almost impossible for us to make the progress we want to make without being able to link the health data to the genomic data, but it massively increases the complexity of data sharing, privacy, jurisdictional boundaries. We also know that patients have got very different approaches. It's partly based on their own circumstance. Dennis told mine. My first wife had one of the rarest of rare cancers that was never being cured. We had to go to the Mayo Clinic to find a treatment protocol. It worked well for the first couple of rounds to the point where she outlived her 2 oncologists. Unfortunately, those 2 oncologists were probably about 80% of the world's knowledge about that particular tumor. When they died, 80% of the world's knowledge died with them. And that kind of left me with a very strong sense of that is insane that it was so focused and it was so unavailable if you hadn't read the one paper that they'd really published on this. So at the back of my mind is that very personal experience of that is a crazy loss of knowledge. When I look at eHealth versus or genetic health versus genomic research on our side, where we came from, on the Global Alliance side, it's all about subjects, human subjects, and papers, and globally. It's about massive sequencing at scale and in high-performance compute. The software that's developed is almost always academic software, and they compete with my Align, and my pipeline is going to be faster and better than your pipeline. It's how they make their careers, and they have a whole different technical language. When we look on your side of the world, we talk about patients and providers, though in both worlds we're now trying to get to that word partners and engage people not as participants but as partners in this work, because certainly from our perspective, if we don't engage the public, and the people who are in the health system, we won't achieve what we're trying to achieve here. This is about partnership and engagement of citizens. But in healthcare, it's gone from single gene panels, just looking at one gene when you think you know the diagnosis, is it yes or no, to one of our local hospitals now talking about a 550 gene panel. Probably only 25 of those 550 genes will be clinically relevant today. The other 525 are probably going to be clinically relevant 2 years, 5 years, 10 years from now when we've done the research. But we can collect all that data at the point of care, knowing that there's actionability to some of it, and then there will be research from the rest of it. You all know about HL7, FIRE. There is a whole group of us working on connecting that. This is just a list of the 9 large groups that I am aware of bringing together the world of genomic science, genomic health, into eHealth. And there's a huge danger in 9 different groups all trying to work in the same space. We just cause more problems than we solve. So we're taking a lot of energy in the next few months to bring those disparate groups together, agree on the use cases, agree on what we need to fix, and then try and fix it together rather than out-compete each other. So our first step is, what are you all doing? What are your timelines? Let's have at least a 12-month schedule to knock off the most important 5 or 6 things we have to do quickly, so that you can get to that same tiered approach to that narrow health information that you need for care decision right here and now, that broader set that I saw on one of the slides earlier, and then that even greater outreach into the world of future research. These are the other stakeholders that we believe we've got to connect with if we're going to get this right. And we have to understand that there are very different drivers. And in this world, it's not so much academic software, and it's not being changed. You've got a significant, and I think it's a massive need to connect with the vendor community, for the vendor community to connect with each other and to connect with us. And I don't believe in this space we can think it's going to be done by academic or hospitals. It has to be done as an entire industry. And that's a different way for us to work on this side of the field. I'll just let you lead that. But the idea is we're never trying to replicate or duplicate what somebody else is doing. There is more than enough work for all 9 of those groups. Canada's underrepresented in that activity. I've got a lot of participation from the US and some reasonable from the UK. I need more participation from Canada. Just another recruiting pitch. I borrowed this slide from Chuck Friedman, the University of Michigan. He talked about a learning health system. And his point was, in a learning health system, you decide to study a problem, you bring together data, analyze it, interpret the results, and it should go over the top into tailored messaging to healthcare, to action, evidence-based guidelines, standards of care. That's what should happen in a learning health system. It often doesn't, because the research is presented at conferences and put in journals, and it's in the public record. But in this province, it took 15 years from when we knew that colorectal cancer screening would save lives to actually becoming a province-wide population-based study. 15 years. I should work out. It frustrated the life out of me that people were dying every year, not because we needed more knowledge, we just needed to apply it into practice. When I put my Global Alliance hat on at this, we've got a great tradition of collaboration on the research side, and it goes back to the Human Genome Project, the International HapMap, International Cancer Genome Project, which we lead from OICR, and the 1000 Genome. In a sense, we had to collaborate. It was so expensive, so resource intensive, that we had to collaborate in order to do the research, because no one country, no one group could do it. So a great tradition on the left-hand side of global collaboration. Same approach, put it into conferences, put it into journals, some obscure, some high impact. But when it comes to applying it to healthcare, all the jurisdictional challenges that you would see to apply it in Canada with 14 different healthcare systems, 10 provinces, 3 territories, 1 federal system, 14 different approaches, I think it's 4 of 24 new cancer drugs funded if you live in Atlantic Canada, 21 of 24 new cancer drugs if you live in BC. Your access to new cancer drugs in this country is not based on knowledge, it's based on your provincial affordability. But multiply 14 health systems in Canada, probably 1,000-fold. And that's what we're dealing with around the world. So I can't fix that global healthcare system, but what I can do is make sure that the work we're doing on interoperability, whether it's APIs or standards or frameworks, is not just designed for the left-hand side, it's designed for the middle. So that means collaboration, connection, talking to you, understanding needs, trying to find ways that what we're doing is that all those 1,000+ volunteers are actually putting their energy into things that will work on both sides of this equation. And what we can then do, as I showed with the BRCA exchange, the matchmaker exchange, we can lift that up into publicly accessible knowledge exchanges that are available whether you're in Entebbe, Uganda, or in downtown Toronto. The same knowledge is available at the click of your computer. You may not have the same ability to act on that knowledge, but at least we can lift the knowledge up. So I think of this as the difference between old paper maps and modern GPS systems. And I think in this city, you probably could always find the CN Tower. You probably wouldn't be able to find Fort York if you didn't live here and know how to speak English and ask for directions. So some things are very, very easy to find. Some things are obscure. You need to be able to navigate. One major jurisdictional difference, and this is brought home to me the more I travel, the US spends over $10,000 per person per year on healthcare. There are 23 countries in the world that spend less than $100 per person on healthcare. We're not going to see, it doesn't matter whether it's going to be called precision, personalized, stratified, we're not going to see that kind of medicine applied in a country that spends less than $100 per person on healthcare. But I'll come back to that in another slide. So lessons we've learned as we've done this: interoperability, mainly through APIs, where appropriate standards, international data sharing by federation and use of metadata, while respecting all those jurisdictional boundaries. Data discovery is a prerequisite to sharing. And then another theme that I heard at different times today, in fact, I think the presentation before me, genomic data and anything that's quantifiable, anything that's digitizable, is relatively easy to manage, to store, to share. It's human-produced data. It's doctors' notes. It's people's different use of abbreviations, unintelligible writing, but often just different languages, different ways of categorizing a disease. So how we as humans describe other humans standing in front of us, or how we describe ourselves, is incredibly varied and incredibly difficult to structure. So we need a lot of help from the people who are looking at different approaches to taking unstructured data and making it machine readable. My last point here on this slide is that machine readable machine learning is critical for this application of genomic knowledge. It could just overwhelm us. It could just be a tsunami of knowledge. If we want to make it a gold mine, a treasure trove, then we have to let the machines do the learning. So I think when I look at global implications, we will have precision medicine, or whatever it's called, in the developed world or the high-income world, and we will need and desperately need, and probably have more impact on human health by better population health in low middle-income countries. So in worlds of infectious disease and outbreak, where there isn't the ability to deal with individuals and they don't live long enough to get cancer, they have real opportunity if we can apply the omics knowledge that we're developing here and apply it across pathogens, across immune responses, and across mosquitoes. So what we learn in the way we share data here has to be applied differently in the developing world, but it's got just as much potential. And we're getting right to the close. So everything I've learned, everything that's been created in the Global Alliance has been built by individuals. So individuals have been essential. The only way we've ever built anything is through passionate, committed, talented individuals. But they can't implement, and they can't adopt, and they can't disseminate. We need organizations. We need small organizations, large organizations, funders, journals, policymakers, in order to implement and disseminate. And personally for me, I can't claim that we're yet global if I got one person in Afghanistan or one institution in Sierra Leone. So I and our organization have got to find ways, if we're going to use the global name, to make us globally relevant and globally engaged. If you want to learn more, then go to our website. We did get a perspective paper written in Science earlier this year, which is a great approach to it lays out our approach to federated data sharing. Contribute in any way you can on your catalogs. There's a survey on values about data sharing. And I usually say to people, if you're enthused about working in this space, join as an individual tonight or right now. But if you've got the responsibility, the opportunity to be a champion within your organization, have your organization join, then it's better to do both. But the easy, quick way is become a member. There's no cost. Thank you.